case of the road itself. And as we already said, particularly the part of the excitation is very much dependent on the hyperpolarization of the road. Now let's see what is the hyperpolarization and how it works there, yes? So, and how can we achieve the hyperpolarization in this case? So what is important is that the part of the decomposing of the rhodopsin, as you can see particularly here, gives us as the result the closure of the channels, and as a result we have the decrease of the entrance of the sodium ions, you know, and as the result, because we do have the simply the part of the sodium ions are which are positive in this case, yes, are mainly associated with the depolarization. In this case, we do have, because of the decrease, in this case, we do have particularly the hyperpolarization. So in case of how it goes through and what are the main type of the steps here, that before understanding the steps, you should see this important sentence. So that normally when we do have the normal conditions and the normal conditions of the dark in this case, yes, when there is no light, it will be dim or high intensity, literally doesn't matter. So there is no excitation, yeah. So in this case, we do have the reduced electronegativity. This is the most interesting part of it, to be honest. So lesser electronegativity means that there is no any excitation, and vice versa, more electronegativity. That is particularly what gives us the excitation. So out of this particular slide, what it is important for us to remember is how can we have the reduced electronegativity? How can we simply achieve the reduced electronegativity when there is the dark period, when there is no activation of the road, yes? So one of the important things starts that the part of the outer segment, as you can see particularly here, outer segment of the road in the dark state, has the part of the channels, which are cyclic GMP gated type of the channels, and that these are particularly the ones where we do have the sodium ions leakage, as you can see. So as a result, what is happening is that when we do have the dark state, sure, as the result, we can even do like that, look. So as a result, we do have particularly the high levels of the cyclic AMP itself. The high levels of the cyclic AMP will give us, as a result, the passage of the sodium towards the road, and or a leakage of the sodium towards the road, the interior of the road. And as a result, what is happening? We do have much reduced type of the electronegativity. So this cyclic GMP presence is just because of the having the dark period, yes, is giving us the reduced electronegativity inside of the road. So as you can see, particularly here, that the part of the reduced electronegativity in case of a roads and cones is approximately minus 40 millivolts. And sure, if we'll compare that with the any other types of the receptors, yes, particularly where we do have the part of the resting potential, which we call, yes, it was particularly the minus 70 to minus 80. Sure, the minus 40 is really something, let's like the different, yes, compared to the to all of the other types of receptors which we've talked about. For example, even the mechanoreceptors, yes, which we've talked about in the case of somatic sensation. So as the result, what should happen in this case? So how can we activate simply the road? Yes. So everything starts with a part of the light. Yes, sure, the light beam, which is giving us, as we have already seen, the part of the rhodopsin decomposition. So we do have the decomposition of the rhodopsin, and as a result here, this decomposition leads to the channel closure. Do you remember I told you already that in this case we do have this channel, the sodium channel, which was cyclic GMP gated type of the channel. We do have the closure of it. So as a result, there is no leakage of the sodium towards the cell itself. Yes. as you can see, particularly here. Now, what is interesting first? So what will be, let's select that, the main idea. So if we do have the reduction of the sodium conduction, yes? So one thing, how, or not even the main idea, but how this happens simply, or which steps are taken to have particularly the reduction of the sodium leakage towards the cell, yes? So one thing that this is short the decomposition of the rhodopsin, which we've talked about, but itself, the activated rhodopsin is doing important thing. It starts to stimulate, as you can see particularly here, the part of the G protein, yeah, which is which we call particularly the transducin. To be honest, that is particularly this particular type of the protein itself. It starts to activate the type of the enzyme which we call the phosphodiesterase. So that is a very nice picture, which you see particularly here. So you do have a part of the disc, a membranous disc, where we do have the rhodopsin with the light which is entering and giving us the decomposition of the rhodopsin. As a result, we do have the activation of the G protein, transducin, as you can see. Then we do have the activation of the phosphodiesterase. And what is happening in this case? That in this case, we do have particularly the conversion of the cyclic GMP to the part of the 5' GMP, and as a result, normally where the cyclic GMP needed for the opening of the sodium channels, we don't have it, so we are reducing the amount of it, yes, and as a result, the leakage of the sodium is simply not present here. So coming back to that particular picture, you can, to that particular slide, we said, yes, so that's why there are three main things what is happening. Activation of rhodopsin, yes, yes. Activated rhodopsin stimulates the transducin, and the transducin activates the cyclic GMP phosphodiesterase, as you can see. And as a result, we do have particularly the reduction of the cyclic AMP, cyclic GMP, amount inside of the cell. So if there is the reduction of the cyclic GMP, sure, the sodium channels which are dependent on that particular structure will be simply closed, and as a result we do have a lack of the sodium ions entering towards the interior of the cell. And as a result, what do we have? So more sodium ions, as you can see, now are simply passing away or out of the cell rather than the ones which are coming in. Because if we will see, I didn't put here the picture, but we do have a very nice picture in this case, to be honest. And I was going through back again this part, you see where this is it. So you can see particularly, again, sure, we do have a sodium potassium ATPase as normally in any type of the cells. And as you can see particularly here, we do have, although there is a part of the leakage of the potassium, still we do have, as we remember, the entrance of the sodium. So as a result, we still had more, what's that, I would not say electropositive, but correctly to say less electronegative type of the how do we call it, the charge across the plasma membrane, right? And for example, compared when we do have the activation of it, yet. So what is important for us in this case is that also what are mainly the types of the light field or electromagnetic field, which we can see particularly, and that's what you see here, that as we said, particularly different types of the wavelengths in the nanometers are the ones which we can see normally, yes? So you can see here particularly the highest one, which is mainly associated with the part of the red color. You can see the part of the in between, we do have a portion of the green and the yellow, and more, let's like that, smaller types or more frequent types of the waves we can see in the part of the violet and the portion of the blue. But okay, as we said, as soon as we do have, okay, the activation of the of the roads, and as a result we do have the activation of the whole chain, let's say like that, of the cells in case of the retina. Yes. Now the question is how the impulse is propagated and where it is propagated. Yes, because in this case for us it's important what part of the retina is activated and what part of the information is propagated. What does it mean? In case of the Snell, I didn't open it here, but I will open it now for you guys and to show you what do I mean. So in the part of the Snell, we do have a very important information with the clinical correlation about the cranial nerve 2, which is the optic nerve, yes? So particularly the optic nerve, as you remember, it passes through part of the optic canal, but the distribution of the fibers is a little bit different. Just a second. Okay, here it is, the cranial nerves. So let's go through the part of the cranial nerve 2 first of all. Yeah, here it is. One important thing which you need to understand, whatever it will be rows or cones and so on, literally doesn't matter, yes? But what will be the visual field in this case? Do you remember, again, coming back to the optics here, we had the formation of the visual field, yes? So please remember that this is particularly what we see from the superior view. As you can see, this is the whole optic pathway. Here are two eyeballs, and normally in the middle we do have a nasal region, so that is particularly the medial part of the visual field, and on the lateral side we do have a temporal part of the visual field. So what is important in this case for us to remember? One thing, whatever is temporal or lateral visual field, particularly here, yes? So you can see that this visual field, so the temporal one, will be always and always, let's like that, is seen on the, or not seen, but active. It will be the light from that region will be always activating the medial side of the eyeball, as you can see. And vice versa, the part of the lateral or the temporal region of the eyeball will be always activated by the nasal or the medial visual field. You see, this is one important thing what we need to remember. Now, so it means that the rods and cones, which are simply localized on more medial surface here, they will be getting the information, mainly will be the rods rather than the cones in this case, but still. So they will get the visual information from the lateral side, as you can see, in both of the cases, to be honest. Here and here, it will be right or left side, right or left eye. Doesn't matter. Vice versa happens in the case of a temporal one, as you can see, particularly here. Now the question is, how these visual fields are propagated. So how they are passing through. Normally, we know that the last destination of the whole pathway in this case should be the occipital lobe, yes? Do you remember there was the Brodmann's area 17 and 18, which were mainly, very closely associated to the part of the calcarine sulci, and as a result, these were the ones which were producing the primary as well as the secondary type of the visual fields, yes? So, but how do we have the propagation in this case? How it enters towards the part of the visual cortex? And here comes the first, that's like that, the first order neuron, which is represented by the optic nerve, as you can see particularly here, yeah? The optic nerve, which is having interesting thing. In case of the, not Guyton, but my here, I wanted to show you that. I forgot to say, to be honest, but we'll say it now. No. Yeah, here it is. Do you see? This is particularly the whole eyeball. So what do you see in this case? Look, this is the portion of the retina. Yes, we do have, particularly in the center, we do have a part of the fovea, which is giving us the acute vision, but very close to the portion of the fovea, we do have the structure which we call the optic disc. To be honest, the words optic disc literally means that this is the, how do we call it? This is the blind spot. Why blind spot? Because in this case, we have only the optic nerve which is originating from the optic disc. So in case of optic disc, we simply do have the axons which are merging to each other, not merging, but collecting together, and as a result, producing the optic nerve. So literally here, we do not have the parts of the rods and cones, and as a result, this region is simply the part of the blind spot. And as we saw particularly here, yes, back again, you can see how it looks like. So the portion of the blind spot, the part of the foveas in both of the cases, also seen here. As a result, we have temporal and the nasal regions of the eyeball, although the visual fields here are seen in a different ways, yes? So in the opposite ways. So what is happening? Do you remember when we said about the optic nerve as it passes from part of the optic canal? Even I told you that particularly it is closely associated with the sphenoid bone there, yes? And the sphenoid bone in the center contains the invagination, which we call the sella turcica. So particularly the sella turcica, as I told you, is the one which is housing the pituitary gland or hypophysis. But anteriorly to the part of the hypophysis, we do have a structure which we call the optic chiasm, or chiasma, as you can see here. So optic chiasma was literally this decussation, yes, of the nerve fibers. But most interesting thing here is that to compare with the other type of the somatic sensation, where mainly we had the decussation of almost whole nerve fibers, yes, and as a part of the second order neuron, as you remember, yes. In this case, we do have only half of the fibers are decussating, as you can see. And both of them, these are the ones which are associated with the nasal or medial part of the eye. So simply to say, this is the parts of the eye which are containing the lateral fields, yes, the lateral visual fields. So from here, or temporal, whatever you will call it, it's lateral or temporal, literally doesn't matter in this case. So only these particular parts are making the decussation in the region of the chiasma. The parts of the lateral sides of the eyeball, which contain the information about the medial visual fields, they are the ones which are not decussating. So as a result, after the part of a decussation, after the formation of the optic chiasma, we do have the structure or the bundle, that's like that, of the axons, which we call the optic tract, as you can see, particularly here. Do you remember when we're talking about the part of the diencephalon, yes? So we were talking about the part of the thalamus, yes? So we have particularly the other part of the thalamus, and that's where, if you remember, we said that we do have one of the structures which we call the geniculate bodies or geniculate nuclei, yes? The very first one, Esther, the very first part, the very first one is the one which is decussating here. So the optic nerve itself is the one which is decussating, simply. Sorry, it's a bit hot here. So what I'm saying right now, yeah? Do you remember when we're talking about the thalami, we said about the different types of the nuclei, and even in the case of the somatosensory type of the pathways, if you remember, they were finding their third order neuron, particularly in the nucleus of the thalamus, yes, particularly the VPL, yes, ventroposterolateral type of a nucleus. In this case, we do have a different way. So here you can see that still there is the passage of the optic tract towards the portion of the lateral geniculate body. And the lateral geniculate body, we said that it is associated with the vision, yes, because you remember, even in my presentation, it was written L stands for light, So lateral geniculate body stands for the vision. M, medial geniculate body. M stands for music. So as a result, particularly, it is associated with the auditory type of a pathway, but this one I will talk later about. So as you can see, this lateral geniculate body, that's where particularly we do have the formation um, of the synapse, and as a result, we do have the formation of the next stage, and this is the part of the optic radiation now. And the optic radiation is the one which is simply enters towards the part of the occipital region of the cortex, particularly to the Brodmann's area, 17, as well as the part of the 18 there. So why looks like that it's not that difficult, yes, to remember. That's true. But what is the biggest problem, and one of the most common things what we are simply asking always, this is the clinical correlations, which I want you to remember, okay? As well as some parts with the reflexes, light reflexes, which are associated with the part of the second, with the part of the cranial nerve 2 and the cranial nerve 3 and so on, 4 and 6, okay? But before that, before we'll talk about these reflexes, plus we've talked about that already several times, here I want to show you in the last part of this book, in this chapter, the clinical correlation. And here it is. Now, what is this clinical correlation? What do you see here? You see? So here we do have the whole visual pathway, again, the copy-paste of what we saw right now. But here we do have additionally the different types of the lesions at the different parts, you see? Which is designated by the numbers. So we do have number 1, number 2, number 3, number 4, number 5, number 6, and number 7. And as a result, on both of the sides, on the right side and the left side, or the right eye and the left eye, they show you what will be the deficits of the which particular visual fields will be in deficit, yes, in this case. So what should we remember? When we saw particularly the distribution of the information, yeah, we said that one of the most important thing to remember is that where particularly do we have the visual fields, yeah? So that if it is the temporal part or the temporal lobe, yeah, sorry, temporal part or temporal region of the eye, then there was mainly the medial field, yes, or nasal visual field. Vice versa happens in the case of the medial field, where medial region of the eye, where particularly we have the temporal field, yeah, or temporal or simply the lateral visual field. So as the result, these particular lesions, let's go through them and let's see why they are interesting. Is that starting with the very first one, which we have only on the right side, as you can see particularly here. So here you do have the portion of the beginning, let's select that, or the first part of the optic nerve. And the most interesting thing here is that the type of the visual field deficit is literally, as you can see in the blackish color, mainly the parts which are seen here. This is the central portion, yeah, right? Then, for example, the periphery. So what do you think? Why this can happen in this case? Look to the place where we have the problem and look to the manifestation. What do you think, guys? So let's think together, yeah? So what may happen with the optic nerve? Yes, no, not at the chiasma level, at the number 1. Do you see, Esther? At number 1. See, this is the optic nerve. It's not optic chiasma, yeah? So what do you think? What can be seen here? Like, what can be the problem? Like, imagine if there would be the trauma, yes? Like, for example, there would be simply a damage to the optic nerve, yes? What do you think? Could we see this type of the manifestation, like where you have the visual field only, which is okay, only in the center and not in the periphery? Could you see something like that? Okay, I will not torture you too much. I do believe it's clear that in this case, the main type of the clinical correlation would be simply the inflammation of the optic nerve, okay? So imagine if there would be the transaction, or particularly there would be the trauma towards the optic nerve, then what we would have would be particularly number 2, yes, as you can see particularly here. So that would be the simply the totally blind type of the eye, yes, in this case. So one thing that you have only one place, as you can see in the surrounding. To be honest, this is the one of the manifestations. There can be different types of manifestations. So that's particularly what we call this condition. We call it optic neuritis. So literally that we do have the inflammation of the optic nerve, okay? But the inflammation can be in the different parts, yes, of the optic nerve, or can be surrounding it. That's why most commonly, what we will see is that we will have some visual loss, but at the beginning of this condition, we will have mainly either the central part, or most commonly the peripheral part of the visual field will be simply lost. Why? Because when we talk about the inflammation, yes, as a result, we have the lack of the passage of the impulses, and as a result, we do have simply the problem in the peripheral parts on the whole peripheral portion. So here, everywhere, yes. So medially, upper, lower, and the part of the lateral ones, they will be lost in this case. Is it clear what I said, or not that much? Good. So what can be? Yes, Anirudh, yes. Either it's not even about narrow, it just the person cannot see the peripheral parts, lateral, medial, the superior, inferior, and they can only see, like, imagine they can see only particular spot, So that's what happens. Although, to be honest, this is one of the manifestations. Sometimes it may happen that we have a problem in the visual field, which is particularly more centrally localized. Again, it can be because of the neuritis. Again, it can be because of the particular type of the inflammation, And that's why there are different ways or different types of manifestations which we can see, But important thing, what I want you to remember is particularly the terminology, yeah? So when we talk about the optic neuritis, so we talk about the inflammation of the optic nerve, even the part of the optic disc sometimes. What is the optic disc? You remember I told you this is the blind spot, yes? Where we have the collection of the nerve fibers, yeah? And in this case, as you said, we do have the problem of the propagation of impulse, yeah? If there is the problem of propagation of the impulse of particular fibers, it means that whatever field is perceived, whatever visual field is perceived by these fibers, that's where we'll have the lack of this visual field, yeah? And please remember, these interruptions in the visual field, that's what we call scotomas. Please remember. So scotoma, so scotoma. So scotoma, this is particularly simply like the, the blind part or blind spots in the case of the visual field. Okay, and that's what most commonly we can see, particularly in the case of the optic neuritis. Now you will have the question, what can be the etiology? By the way, I need all of this information. I want you to read it very well, and I want you to We learn it very well. So there are different types, to be honest, of the problems, but most commonly when we talk about the inflammation and as a result of visual loss, particularly first thing what we need to think about, this is the degenerative type of the disease. This is particularly the multiple sclerosis, because you know that the multiple sclerosis, this is the problem of the myelin sheath. Yeah, so there's a degeneration of the myelin sheath. Well, that's what we call the demyelinating type of the disease. Yeah. So the multiple sclerosis has one of the first manifestations, one of the most common manifestations. This is particularly the optic neuritis, which can be seen. And as a result, what is happening? We do have gradually the worse and worse visual acuity, and at all the whole vision, particularly on one eye or sometimes on both of the eyes. It's up to which particular optic nerve, because when we say optic neuritis, it means that we are talking about literally one optic nerve most commonly, or maybe sometimes two. So if it's one, as you can see particularly here, that's why the right visual field, yes, will be defective, but the left visual field, if it's not also inflamed, it should be normal. You see? Like this one is the most, let's like that, complex type of the condition, this optic neuritis. But as we go through, for example, number two is simply the damage of the whole optic nerve, particularly on the right side. But what do you see that everything happens before the optic chiasma? Yes, before the optic chiasma, if we do have a trauma or any other type of a problem, it means that the visual loss will be ipsilateral to the injury. Yes. So on the right side, I have optic neuritis. On the right side, I do have the damage to the optic nerve. So as a result, on the right side, either I will have the scotomas, for example, or in the case of the total, for example, I don't know, dissection of the optic nerve. In this case, I do have the total blindness. You see, but again and again, ipsilaterally to the injury. Okay, is it clear what I'm saying till now? Yeah, good. Now the next part, what do we have, is particularly the portion of the optic chiasma. Yeah, so when we come towards the optic chiasma, we can have the several types of the injuries. Either, as you can see, through the whole optic chiasma, where particularly we do have the decussations, or at the region where the part of the temporal parts of the eyeball, yes, are literally passing on the same side, so ipsilaterally. So in the number 3, or it will be number 4, to be honest, they do have a different types of manifestations. And why? If we talk about the number 3, then it will have, as you can see here, the part of the ipsilateral type of the manifestation, but the manifestation will be, that's what we call hemianopia or anopsia. What is hemianopsia? Yes, so hemi, half, no, opia, so optic part, half of the optic part is not present, yes, or injured, yes. So hemianopia or hemianopsia is important. Why? Because if we talk about, as you can see here, the portion of the number 3, where only the temporal parts, yes, of the eyeball are injured, then it will be ipsilateral hemianopia, yes. But what visual field will not be seen? So this is number 3. Do you see? So on the same side, this is the right side. So on the same side, we'll have hemianopia. Half of the visual field is the problematic, but which? The lateral or temporal one, or nasal or medial one? So what do we remember what we said here? Because this discontinuous line, yes, is showing you that it comes where? From the temporal part, yes, from the lateral part of the eyeball. As the result, the information which will be perceived here, this is the medial or nasal visual field, yes? As a result, what do you see here is that in the number 3, we do have the nasal field on the right side is not seen. So this region will have the problem with the vision. So this visual field will not be seen simply. Is it clear why or not? It is. Good. Now, if we talk about the part of the optic chiasma itself, this is even more interesting. Why? Because where we do have the decussation and the decussation of the medial parts, as you can see here, this decussation, you remember, yeah, contains what type of the information, where it comes from, this particular information of the lateral visual fields. Am I right? Because it is the medial part of the eyeball, and as a result, the lateral or temporal visual fields will be perceived by this region. Now, because they are decussating here, yes, and we simply have the transection of the optic chiasma, then what is happening? It means that there is no propagation of this information. So again, I should have the hemianopia. So again, I should have the problem with the half of the visual field, yes? So when we do have the problem with the simply only the half portion of the visual field, but what will be that portion of the visual field? So we have from one side temporal portion, from the other side temporal portion, yes? So it will be bitemporal type of the visual loss. And as you can see, particularly here, this is the number 4. You see, lateral and lateral in both the right and the left eyes, yes? So compared to the number 3, as you can see, because here we have only the transaction of the part of the optic chiasma on the right side. That's why it was ipsilateral, yes? But in this case, you do have on both of the sides, and as you can see, particularly both of the sides are lateral type of the sides, and again, we do have the loss of the half of the visual field, okay? As we continue through, all of the others, to be honest, will be the same, you know? So there will be the problem in the part of the optic tract. There will be the problem in the part of the optic radiation. There will be the problem itself in the part of the visual cortex. Literally doesn't matter. Why? Because after the optic chiasma, already we do have the passage of the information where, as you can see, particularly here, that here we do have the part of the temporal portion of the eye, as you can see here, temporal portion of the eye, as well as the nasal portion of the eye, both of them together. So we'll have the problem, like if we have it on the right side. Yes, for example, if the optic tract and the right side has the injury, then what will happen? All of the visual field, which is perceived by the right side temporal and the left side nasal region, and in this case it will be the portion of the medial or nasal as well as the temporal part on one side. You see, in this case we do have again and again the hemianopia, but in this case the hemianopia normally should be on the one side, yes, simply to say. The same happens in the case of, so that's why number 5 you can see particularly here. The same happens for the number 6 and the same happens for the number 7. So everywhere, because after the optic chiasm there is no difference, let's say like that, yes. So as a result, we do have particularly the same type of the manifestations. Is it clear till now what I was saying or not? Do you have any questions, for example, or I don't know, anything? Okay, what I want to talk about is that, sorry, Namrata, so the nasal part of the eye right side. Just a second. Let me read the question, please. So the nasal part of the eye right side, same part will be affected, same type of manifestations. You mean number 5, 6, and 7? Okay, let me explain it better, okay? So, where was the book? Ah, here it is. So what do we have in this case? Look, because after um, because after the optic chiasm, where the idea of optic chiasma is that we have the decussation only of the half of the nerve fibers, yes, of the optic nerve, and not the whole. So do not compare these to the ascending tracts, for example, where mainly approximately all of the fibers are decussating, yes, in the case of a second order neuron. Here you don't have something like that. In this case, you have only and only the half of the nerve fibers which are decussating. And these nerve fibers are the ones which are coming from the nasal part of the eyeball, which percepts the temporal visual field. Yes? Yes. After the optic chiasma, on one side, which is, for example, in this case, as you see, right side, yes? So in the case of optic tract injury, optic radiation injury, visual cortex injury, doesn't matter in all of these cases. What do we have? We do have the nerve fibers which are coming from both of the eyes. Am I right? Yes? Because one, as you can see, yes, the picture represents the right eye, that's true. So as you can see particularly here, that in the bluish color, yes, we do have the, on the right side, in the bluish color, we do have the temporal or lateral part of the eye, where, I mean, the nerve fibers coming from the lateral part of the eyeball, which contains or percepts the nasal or medial visual field. Am I right? So this means that the opposite part of the visual field here, so this is the right eye, in this case it is more left region, yes? So this visual field, so the medial visual field or the nasal visual field will be sure defective, yes? But at the same time, in the part of the optic tract, we do have already decussated one half of the nerve fibers, which comes from the opposite eye, because this is the right side, yes? This is the right hemisphere, so as a result, this is the right side. So it contains one ipsilateral temporal parts and the contralateral medial parts, yes, of the eyeball. And as a result, both of the structures will do have the same side problem, yes, but for the temporal region of the, or lateral region of the eyeball of the right side, it will be the nasal visual field. For the medial side, it will be the lateral visual field, yes, the temporal visual field. That's why normally it is the part of the contralateral visual field problem, you see? So if it is on the right side, mainly the left portion will not be very well seen, we could say. Although it's even not correct to say, to be honest, because what does mean the left visual field? Yes, it simply means either we have a temporal part of it, or we do have the nasal part of it. That's why this type of the manifestation, where we do have the hemianopia, so we do have the half of the visual field which is defected, but the side here is the same. So if in the number 4 we had the bitemporal type of the hemianopia, yes, in this case we do have the same side. So on the same part, that's what we call homonymous hemianopia, where homonymous means that it is on the same side part, yes? So if you see here, homonymous hemianopia or hemianopsia, yes? What part of the visual field is this? This is the left, yes? So as a result, we call it left homonymous hemianopia. Is it clear? Vice versa, if you have the problem with the optic tract or optic radiation or the visual cortex on the left side, then you would have, sure, the contralaterally, the right homonymous hemianopia, yes? So literally, again, the same idea, because after the decussation, you have half, let's like that, of the nerve fibers already decussated from the nasal region, and the half of them, which are from the temporal region, they are not decussated. Is it clear till now? I do believe it's understandable, yeah? Okay. Now we do have the next portion, if I remember correctly, but let's have some rest back.